This is Dr. Caitlin Krebs. She graduated from veterinary school at UC Davis, and she has career aspirations of becoming a neurologist. But right now, she's downstairs in a small animal hospital doing a small animal rotating fusion. Take it away.
Thanks, Dr. Butler. Welcome to another edition of today's clinical conference. Today, we're going to be talking about a brain tumor in a young French bulldog, and I think the poster kind of spoiled it a little bit by telling you what the brain tumor is in our young French bulldog, but pretend like we don't know. So, to get started, we have a 4-year-old male intact French bulldog. He presented to us with a 2-month history of seizures and personality changes. And what that looked like is he became really, really aggressive towards everybody except his owners. He would go after strangers, other dogs, pretty much anybody that wasn't his mom and dad. His local veterinarian started him on some phenobarbital at a pretty standard dose, and he's continued to have seizures. So they increased the dose of phenobarb, and he continued to have seizures. So then they added in some zonisamide, and just a couple days after starting that, he started to have tremoring. So they discontinued that, and then he presented to us. We performed a neuro exam, and what we found was that his mentation was mildly obtunded, and he was quite aggressive. It was quite difficult to examine this adorable little Frenchie. In his gait, he was ataxic, tetraplegic, and he was the worst in his right front limb. He would just, even sitting in his owner's lap, just knuckle over, like didn't even seem aware of where his right front limb was especially. All of his cranial nerves were intact, and his conscious proprioception was delayed in his right, both the front and the back limb. We were unable to evaluate his reflexes due to his very angry temperament. We did not want to get bitten. And on palpation, what we could palpate, he did not appear to be in any pain. So, when we think about our neuroanatomic localization, we localized him to the left cerebothalamic region. And that might not be a localization that many of you guys have heard of before. We can localize to the left cerebrum based on the right forelimb and right-sided deficits, but we can also kind of add the thalamus in there, which is circled here in this little red spot on the screen, because all of these sensory tracts also go through the thalamic region, and so a lot of times cerebral disease and thalamic disease look quite similar, so we couldn't rule out some sort of a thalamic lesion based on our neuro exam. So, some differential diagnoses for seizures. When we think about these, we divide them into extracranial causes and intracranial causes. So some extracranial causes of seizures include toxins and metabolic derangement such as electrolytes and endocrine disease. With our intracranial disease, especially in a young dog, we always have epilepsy on the list. But we also can't rule out neoplasia in this guy, which, getting to the punchline, he had some neoplasia. But we definitely had to consider epilepsy here as well, since he is a young dog. So in order to rule out extracranial causes of seizuring, we performed a complete minimum database, and luckily for our patient, he was completely normal. All of the tests we ran were unremarkable, and so, like our cartoon surgeon here says, a little surgery would make us all feel better. So, before going to surgery, we proceeded with an MRI. Just to go over a little bit of what we're seeing here on the screen, this is a T2 weighted image on an MRI. We have a couple of different ways that we can look at the brain. So T2 is one of the views. We also have T1, which the fluid is dark in T1 and bright, as you can see here in the ventricles, on a T2 image. In case you guys missed it, we have a large tumor. So the tumor here on a T2 image is well demarcated, and it lights up really bright. On a T1 image, this tumor actually is dark, similar to the fluid. So different ways that we can look at the tumor. This is quite remarkable. When we saw this, we're like, whoa. So we started dabbing on some prednisone to kind of decrease the inflammation while we were planning for surgery, and then also some levetiracetam to help control his seizures. While we were waiting to go to surgery, he progressed to stumbling, staring into space, and he became really unaware of his surroundings. Luckily though, he had no seizures, so we found what controlled his seizures, but he continued to get worse. So, what are some differential diagnoses for a large brain tumor? We have a couple different options here. Glial tumors include astrocytomas, oligodendrogliomas, ependymomas, and choroid plexus tumors. These are all primary brain tumors. However, we can't completely rule out a metastatic tumor, and some options for metastatic tumors include hemangiosarcomas, carcinomas, histiocytic carcinomas, and lymphomas that like to go to the brain. So, we took Dazzy to surgery because large brain tumor needs to come out of the brain, and we performed a midline incision, dissected the muscles away from the cranium, and then actually performed a left rostral craniectomy. So we removed part of the bone in his skull, scooped out the large brain tumor. I did not do that. I was there, I did not do that. And then we ended up replacing the cranium, not with the actual bone, but we used a substance called polymethyl methacrylate, which is this really hard substance that ends up forming a hard substance like bone. So I have this little guy here. I'll pass it around for you guys. But basically, it creates an exothermic reaction where it gets really, really hot and then cools down into the shape that you've shaped it into. So the surgeons give the student a little piece of the PMMA so that we can tell them when it's cool enough to place on the bone. If we can't touch it, it's too hot. So, performed surgery on Dazzy, replaced the hole in his skull with the PMMA so that he no longer has a hole in his skull. And then he recovered overnight in the ICU. You can see his incision here is quite gnarly. It was pretty much the entire length of his head. We kept him in the ICU for close monitoring overnight so that we could monitor for seizuring, monitor his mentation, and then monitor for increases in intracranial pressure as well. And luckily, he did quite well overnight and was able to be moved to our step-down wards the night after. We submitted the brain tumor for histopathology, and what the pathologists were looking for on our histology sample were a couple different things. They looked for the overall cellularity of the sample, and as you guys can see in this photo, it is quite cellular. There's lots of cells here. The other thing they look for is microvascular proliferation. So we have quite a few little blood vessels all in here, sign of a higher grade tumor. And then the other thing that the pathologist noted was that there was quite a bit of anisokaryosis, which is differentiation in the cell nucleus size. And all of these factors combined creates what they saw as a grade 3 oligodendroglioma. That is the highest grade and unfortunately carries the poorest prognosis. So let's talk a little bit about oligodendrogliomas. Interestingly enough, in a study of about 10,000 dogs performed not too long ago, brachycephalic dogs are overrepresented with these tumors. They found that boxer dogs actually had over 50% of oligodendrogliomas in their population of dogs. Other breeds that were predisposed are Boston Terriers and, like Dazzy, Bulldogs. There's new research that's still being researched that looks into genetic risk factors, and interestingly enough, they found that the gene that codes for the brachycephalic syndrome could also be linked to the gene that could possibly be causing oligodendrogliomas. Still more work to be done in that area, but it's an interesting connection there. And unfortunately, survival times are not well documented with surgery and radiation in these tumor types. Unfortunately, many patients don't go to surgery or to radiation, so it's not well known exactly how long these guys live. A couple of case studies have reported that they can live approximately 1 to 2 years with surgery and radiation. But again, not well documented, so it's not good concrete information to tell our owners. So, our outcome here, our patient underwent a full course of radiation. So he had 20 doses of radiation, that's 5 doses, 1 a day, for 4 weeks. It's quite a bit of radiation. And post-radiation, we did another MRI to evaluate how he was doing, if there was any brain tumor left. And this is his scan post-radiation. There is a small area of hyperintensity here on the screen. It's unknown if that is actually part of the tumor growing back or if it's scarring or inflammation from where we removed the tumor there. But overall, clinically, he's doing quite well. We're now about 7 months out of surgery. He has no CP deficit. He walks like a normal dog, and surprisingly, also acts like a normal dog. This is a picture here of us cuddling 2 days after surgery. Before surgery, I couldn't even touch this dog without 3 or 4 other people helping to restrain him. So it was quite a remarkable turnaround, and we actually became quite friendly, and he would like eat out of my hand. So his personality really did change after we removed the brain tumor. So some take-home messages for you all. MRI really is the gold standard for most neuro diseases, but in this case you probably could have found the giant brain tumor on a CT scan as well. Brain tumors are not always a death sentence. Most patients will die from their brain tumors, but the outcome, especially for Dazzy here, is quite good. He'll get hopefully another year or so of life. And then just something else to take home is that some breeds are predisposed to certain tumors. So even though Dazzy's a 4-year-old dog and epilepsy might have gone to the forefront of your differential list, some breeds like French Bulldogs are predisposed to certain tumors like oligodendrogliomas, and so we can't always rule out neoplasia in these young animals. We should always, unfortunately, consider cancer. So, some acknowledgements. I'd like to thank the UC Davis Neuro team. I'd like to thank Dr. Foley for being my advisor for this presentation, the ABC Intern team for listening to me practice, and of course Dazzy and Dazzy's people. And this picture here is from Dazzy on his last course of radiation, and as you can see, we became quite good friends. So now I'll take any questions.
More related to the surgery as opposed to the neurology, but great taste and interesting. Was there anything to do with the dead space that was created by removing such a large tumor? Do you know?
I don't believe we did anything for it. We expected some brain swelling afterwards, so we ended up replacing the meningeal layer with something called Vetrix, which is like a meningeal replacer. And then put the PMMA on top, and then just kind of expected the brain to swell and the ventricles to like re-expand. So.
But you created some room for it to swell.
Yeah.
Thanks.
All right, thank you.